Pakistan, 2% of the population had the vaccine, around about 8% in India. In Egypt, we'll call it less than 5%. USA, 40%, UK, 50%. Quite a lack of equity of access, which is expected. How are we reconciling the difference with, we know that no one is safe until everybody's safe and everybody's received the vaccine? I'm going to start with the UK and perhaps Tonia. How are we going to reconcile this? How penetration and the rate of vaccination is very variable from 2% to 50%.
I mean, in my personal opinion, I think we need to redress this balance. And I think a number of scientists and epidemiologists have suggested that, you know, it doesn't sit right with me that in the UK we've vaccinated over 50% and we're going to start vaccinating, you know, young, healthy people who are at low risk of severe disease, whilst in other countries, people who are at significantly high risk, like healthcare workers in lower middle income countries, have no access. And this is supposed to happen through COVAX, you know, which is a kind of unprecedented global collaboration between WHO, UNICEF, Gavi, which is a global vaccine alliance, as well as CEPI, to gather charity and, you know, high income country funding to allow equitable vaccine distribution. And they have, you know, secured 1.5 billion doses for this year to vaccinate, with the aim of vaccinating 20% of the population in these low middle income country settings. But I read a report yesterday suggesting that only 1 in 5 of these doses have gone out, and there have been a number of barriers, including export bans, you know, difficulty in sourcing raw materials, you know, countries hoarding doses. You know, there are lots of barriers, both from kind of national governments. So I think there really needs to be a wider conversation for high income countries to try and release doses, because many countries like the UK and Canada have purchased multiple doses, you know, 5 to 9 doses, enough to vaccinate entire populations many times over. So I guess, you know, understanding the bottlenecks that I think all three of you have described in terms of getting supply, but also, you know, helping to improve capacity. You know, I think both in Egypt and in India, there is manufacturing capacity to expand local manufacturing capacity, so you're not reliant on other countries to provide doses.
Sure. Thanks. I'm going to just move on, and I'll start with Dr. Wagida. One of the issues about transmission and areas like education, schools and universities and travel ban, etc., etc. What is the situation and the government strategy about traveling within Egypt and outside Egypt?
Yeah. As regards to schools, you know, they are trying to do this e-learning program, and also universities. And whenever there are cases, they may close classes or schools. Regarding prohibiting movement between governorates, you know, not yet started. It's free for travel. And traveling abroad, you know, depends on the country we are traveling to. There are, you know, regulations and restrictions in certain countries. Others, you know, you can go and follow their regulations.
Thanks. So I'm going to ask our Dr. Faisal regarding a practical question, and which is somebody's asking from the audience about, I've received a vaccine from one type and then I'm waiting for the second dose. Could I mix and match, i.e. could I have AstraZeneca from one and then another one, mix and match what I have? Dr. Faisal, what's your practice there?
So that's a really common question, and the answer is we don't know as yet. There are a number of mix and match studies that are ongoing. We're doing some over here also to try and see if you can mix and match, and that's actually to offset some of the vaccine, if you have less supply of one or the other. But as of now, we actually do not recommend mixing and matching vaccines.
Ram, how about vaccination effectiveness against mutating virus that we don't really know what's the rest of the mutation or when is the mutation going to continue or stop? Ram?
Yeah, I think the answer is we still don't know. One thing we know for sure that taking the vaccine is any day better, even if it is not going to give a complete coverage, it is better than not getting yourself vaccinated. So I think in spite of the mutations, there is some vaccine protectiveness and effectiveness, so we should go for it.
Thank you. There's another question that came from the audience saying, we used a brilliant technology to press on very speedy production of COVID vaccine. Could you tell me why the same was not applied for HIV and Hep C vaccination? It's a pretty political question, and perhaps I might ask Dr. Wagida and then pass on to Tonia to get our perspective on that.
Yeah, I think there are several trials for to develop the vaccine for hepatitis C and HIV, but no success. So this question should go to the scientific community to enhance their action. And but we are glad that they developed the vaccine for COVID-19. It did not take all this time.
I think this pandemic has shown what throwing a lot of money into something and lots of scientific minds together, I think the development of the messenger RNA vaccine is very, very exciting. I think we can it could transform, preventative, vaccinations for other pathogens as well. So I think one positive thing I hope that comes out of this is that, there's been a lot of scientific advancement that could be turned towards a lot of other infectious diseases. Also, the understanding that surveillance is really, really important, and developing capacity in countries that don't have it, particularly genomic sequencing. I think certainly I do a lot of work in Africa, and the kind of molecular testing and genomic capacity has expanded really massively in this time. So actually a question that I want to pose to the three speakers is, what is the capacity in your country in terms of genomic sequencing? Because we now know that this is really important to understand the variants that are circulating in your country, and what can other countries do to support you in this respect? I don't know who wants to start first. Wagida?
Yes. Yes, we have the experts who can do it, but this kind of research activity is very expensive. So it is on the research basis, not for the public. Yani we cannot do this for all the population, but it is restricted to research areas. So the availability of samples for to differentiate between the strains or the, it takes time and need cooperation and money.
Yeah, for India also it is the same in the sense we have the capacity to do it, but the sample processing will be limited. I think we'll have to take 1% or something of the samples to do it. It is ongoing, it takes time, so I think we have to wait and see.
And then same here in Pakistan, though I do want to add that WHO is actually helping us and funding some national surveillance in 2 sites, Aachen being one of them, where we'll be doing random samples just to see what's out there. So.
Excellent. There's a question specifically for you, Dr. Faisal, from your community saying, when will Pakistan start manufacturing a vaccine locally, as in Pakistan?
So I do know that a number of drug companies are actually now working actively towards manufacturing. In fact, for one, and without giving details, they're expecting manufacturing by the 3rd quarter or the 4th quarter of this year.
Thank you. I'm going to go around the table now because we're just about 3-4 minutes left for us to conclude. And I'm going to ask you, with this terrible pandemic that we had for a year, and then the hope and the euphoria that vaccination is just about universally available for all of us, and then some countries hit with a second and third wave. What have we all learned over the last 12 months that can perhaps help us face what is ahead of us, which is in a way unknown to a degree? And I'm going to start with just whoever is in front of me just now, which is Ram.
Right. I think we have learned several lessons and we still have a long way to go in learning more lessons. The thing which I would tell you from my perspective is I think COVID is just not a physical disease. Both the effect of COVID directly, plus the fact the anxiety, the paranoia it creates. For example, right now in India, we can say it's a second wave, which I feel is actually less intense than the first wave. But the scare, the fear, everybody who has a little itchy or scratchy throat just goes and has a test done. Most people are asymptomatic. Of course, there are symptomatic people, but everybody is panicking. This is the lot who are now affordable, who are knowledgeable, educated, who are panicking to get into the hospital just because they are hypertensive or diabetic. And that is the reason why we have a crisis now in India, because they are the general hospitals, the government hospitals are not a problem, but the private hospitals are swamped now because everybody wants to get in there. With regard to the vaccines, I don't think, as Tony said, it is as simple as ramping up production. I think we will get there another 6 months' time, but it's a fundamental mindset. I've been into adult immunization for over a decade, and there is a block in taking vaccines, which is much more in the developing country than in the developed nations. So this has to be addressed. It's like the tragedy of the commons. I don't think we'll ever have an answer. We will, once we ramp up production, there will be mutants developing. This will become like an influenza annual vaccination. So I think COVID is going to be with us for several more years, if not decades. We have to learn to live with it.
Thank you, Ram. Dr. Faisal?
Yeah.
So thank you. So yeah, I agree. I echo everything that that Ram just mentioned, and also the fact that this pandemic has really brought to light the differences between healthcare delivery between the countries and what is available to who and when. And despite all our plannings, we still are not able to vaccinate people. Part of it is obviously vaccine hesitancy, but a big part of it is not being able to get the vaccine. And that is sort of just the frustrating part of it. And I think for the future, maybe somehow ensuring more equitable distribution of resources, be it vaccines or knowledge or medication, maybe would level the playing field for all of us around the world.
Great. Thank you. And Dr. Wagida?
Yeah. Yes. I think COVID-19 have also lessons learned that we know the importance of disciplines. First, the public health importance, including the information and the statistics and the preparedness for epidemics and disasters. It's very important to take action towards the surveillance system in countries, and also the discipline of mathematical modeling. It shows an importance that not everybody is expert in this. There are also advantage of using the technology like what we are using now for education and for saving time and money, and we were very hesitant to use it before, and now everybody's using it. So my idea is we should be ready, and research to be taken more actions for evidence-based decisions for the decision maker.
Thank you very much. Finally, Tonia, what would you like to tell us?
I just think this pandemic has shown us that, infectious disease is a global problem. COVID doesn't respect borders, and that, multiple speakers have said that, that it's no one is safe until everyone is safe. And that includes kind of rapid sharing of information, having equitable access to vaccines, and learning from each other, because I think, some countries have developed innovative solutions. There's been common themes shared about vaccine hesitancy. This morning, I read an initiative in Turkey that's been very successful in healthcare workers and and doctors calling people who are not turning up for their clinics, and then they go out with community leaders to try and persuade people, hopefully not coercion, a gentle persuasion for people to take vaccines. So there are kind of initiatives, and we can all learn from each other. But different countries face different challenges, and I think we will only beat this virus if we all work together.
Thanks, Tonia. I'll take a different tack, and before we conclude, I think we would never forget that this has been a massive humanitarian crisis. We lived through it for the last almost 18 months now. It has taken a massive toll on people's mental health. People's lost their jobs. People lost their livelihood. We are missing the most basic act of being able to give a hug to each other and to stay with each other, have a meal, even whether this is in Ramadan, whether this is in Diwali, whether this is in Easter and Christmas. This is a major, major impact on all of us. Nonetheless, there is a hope that we will get to the other side with you. Now, finally, the very final 30 seconds, the college is proud to have fellows like yourself. Now, after an hour, I'm going to call you Faisal, Ram, and Wagida as friends and fellows of our college. It's been a pleasure with Tonia supporting the act of co-chair. We really learned a lot from you. We were interested to hear about our fellows and members. It's 50%, almost 50% of our fellows and members of the Royal College of Physicians Surgeons of Glasgow is out the UK, i.e. internationally, and we feel it's our privilege to reach out to you in Egypt, India, and Pakistan, and also Lanarkshire locally and globally. So we're delighted, and I can assure you we normally don't run over time, but I'll tell you what my indicator is. The number of delegates that started and is still listening to you and to the discussion is still virtually unchanged. It means people are engaged, people enjoyed what they are listening to, learning hugely and profoundly from your experience. Everyone have a good afternoon and stay connected with the college and stay safe and keep well. And my regards to the population of India, Pakistan, and Egypt, and globally. Have a good afternoon, and thanks very much indeed, everyone. Happy Ramadan to everyone, both Faisal and Wagida. Have a good afternoon. Bye-bye for now. Thanks, Tonia. Hugely appreciated.